So Brian, what if you're a really small patient, maybe a tiny woman, and you're working with a big football player or something like that, where you've got a mismatch with sizing? How do you deal with that then?
You would never teach a technique that everyone could not use. Now you get a great big football player and some small therapist. How can she reach around or reach up and reposition the bones? But don't worry, help is at hand. Thank you. Now here we have a belt. The belt is placed around my thighs, upper thighs, and it should be comfortable. When I lean back, I'm now going to apply a dorsal glide.
So it's just the same glide that you did with your hands, exactly, but now you're using the belt.
The direction is slightly down. It's at 30 degrees. Here we are, just apply it. There's the fixation. 30 degrees, you've got a spare hand, just sort of just leave it there, just to, help the belt behave. And I just pull back. Can you feel that coming back?
Yes.
Goody. Now, while I'm doing that, could you please lift your arm up sideways? And as he comes up, you'll notice my body moves and down.
And then external.
And up again. Oh, that's fine. Whatever movement's painful, you're going to see if the pain's disappeared when you put the belt.
And you're moving with him as he goes. You've got to move. And if you don't move, it blocks him.
Yes, it just will not function. Now, if this takes the pain away, how are you going to get a long-lasting effect? I think that if you can work the shoulder, use muscles of the shoulder, and make the shoulder function with some activity while the bones are correctly positioned, you bring the memory back to the joint. So that when it's done something for a while, it stays in position.
So we could add a little weight here to fire that rotator.
Yes, now, as we're going to do it, just watch what I'm going to do with him. There is the repositioning. You could add some weight, and he goes up. You can do this for me.
Yeah.
Yes, be useful. Up he goes.
Dumbbells in the clinic are handy.
Now, watch my hips. I have to move with him to keep that repositioning.
So that early dance career really is paying off for you, Brian.
I have many talents. Looks good.
A little dumbbell in his hand might work nicely.
Yes. Well, can I just make one point? You may give him a weight to hold and say, just go forward. But he must not overreach. Because if when he's using this technique, he overreaches, this is counterproductive. He is now taking his humeral head forward in the glenoid fossa. This I do not want to occur. He will just go just short of overreaching.
So really this technique is a combination of things that's going on. Not only are we repositioning that joint, we're also firing the rotator cuff perhaps in a more advantageous position. Yep. We're retraining the whole glenohumeral.
It's even simpler than that. You're just making the shoulder function. While it's in the right position, it gets used to being in the right position and it stays there. And it does. We will have people that have shoulders that haven't moved in full flexion. After doing a few of these, it's working. People say, why does it stay there? I say, well, why shouldn't it? Why did it stay in the bad position? That's more of a problem to solve, not why would it want to come back and stay in the correct position.
One of the other things that we've also seen with this technique, with the new folks trying this technique, is care with the belt. In some cases, people tend to like to really pull back quite firmly with that belt and use a lot of their body weight, and that's problematic. So we can see here with what Brian's doing, it's a very light but effective pull, minimum force necessary to abolish the symptom as he elevates.
And remember, it never hurts. Any pain at all, you're not using this technique. Sometimes people say, oh, that feels better. No, I don't want you to say it feels better. I want you to say, I have no pain. And that's important.
Excellent.
But it's changed the treatment of shoulders for me. It really, it's just an incredible thing to do, to reposition joints anywhere. Reposition the surfaces and see what happens. It's an assessment.
Brian, I wanted to ensure, listening to you and Brian Folk talk about this technique, I want to make sure the viewers understand some of the treatment principles, guidelines, how many repetitions you might do. What are you going to do in terms of, let's say you have a patient come in and they're a post-op patient and they're out a couple weeks. would you still maybe treat a post-op shoulder scope with these techniques?
Yes, you can, because you've got this guideline. Whatever you're doing is producing no pain. So that's the first thing. So if it's a post-op shoulder, if it's a traumatized shoulder, it doesn't matter what the history is, try the technique as part of your assessment. Make sure you've communicated with the patient and the patient understands that they will feel no discomfort with the technique. And if they do, they're to tell you immediately.
Yeah. Is it fair to think that there are contraindications to these techniques, but more often there are precautions that we would
precautions, that's a good word. I'm fairly bold.
Right.
I would try them because I know if I'm not hurting anybody.
Right. It's the pain-free.
It's the pain-free. Don't ever neglect that necessity of pain-free.
Right. So how many repetitions are we going to do with a patient? Let's say they're not irritable and it's not the post-op patient that you worry about stirring up. How many?
With an extremity joint, the shoulder, you can do 3 sets of 10.
Yeah. All right.
Now, you get somebody with a painful arc and they come down, that's a painful arc. Reposition the humeral head, give them a weight, do 10, put the arm down, let the pressure off, just test. And you'll find after 10, if this treatment's indicated, they say, hey, that's a bit better. You do another 10 with the weight. After the second 10, retest, hey, that's better still.
Yep.
And you'll normally find after 30, most of the pain's gone.
Right.
The painful arc has gone.
And you talked about long lasting. So the gentleman comes in, you treat them on a Monday, now they come back on a Wednesday, long lasting. What sort of, you expect them to carry over, right?
Yes.
Some other improvement? Do you have a general rule of thumb that you would say you would like to see them have how much improvement or what's happened with that?
40, 50, 60, 70, 80. It just depends on the particular patient and the pathology.
Right. So at least something like 50 or 60% maintaining the range that you increased.
Yes.
Right.
There are exceptions where if you've got a bad neck and you've done something and they're heaps better and they come in 2 days later and they're just as bad again and you find that they sleep on their tummies.
Right.
That's a traumatic position to sleep in if you've got any neck pathology. So unless they stop sleeping prone.
Right.